Bismillahirrahmanirrahim. Today we talk about the intestinal obstruction. Intestinal obstruction is a common condition, particularly in the surgical units of the hospital, and intestine can become obstructed mechanically, or it may be obstructed by problems in the nerves and muscles, and in this case we can say that this is a functional type of obstruction. Hirschsprung disease is a disease of the newborn children, and it is a functional type of intestinal obstruction in which there is no mechanical cause, but the enteric nervous system, particularly the Menteric nervous system and the Meissner plexus, nervous plexus that is situated in the submucosa, they are missing. Now, intestinal obstruction most commonly in adults occur, it is due to mechanical obstruction. So, whatsoever there may be something physically obstructing the intestine that doesn't allow the food and digested contents or fecal matter to move forward towards the rectum, or this obstruction may be due to absence of the normal peristaltic contractions. So overall, the intestinal obstruction occurs when the fecal matter or digested food cannot move, and the normal peristaltic contractions, they are disturbed. The mechanical causes of intestinal obstruction include adhesions, which are most commonly seen post-operatively, and formation of bands or ligaments between the parts of the intestine. It may be in the form of protrusion of the intestinal contents into the weakened and or defective area in the peritoneal wall. It may be in the form of volvulus, in which the intestinal segments, they get twisted around a fixed point, or it may be in the form of intersusception, when one part of the intestine is inverted or invaginated into the other part, and the physical presence of tumors in the lumen of the intestine. The functional obstruction will be caused by any condition that damages the muscles and nerves in the intestine. We know that the intestine has a sympathetic and parasympathetic nerve supply, and in between the circular and longitudinal muscles, here lies the Menteric plexus, which are mostly associated uh, with intestinal contractions and peristalsis. And in the submucosa, between the mucosa and the circular muscle layer, is the Meissner plexus, which is mainly associated with secretions, absorption, and the two nerve plexus, they are they communicate with each other. So many intestinal diseases or other diseases other than intestinal may cause damage to the muscles, nerves, and may cause the functional intestinal obstruction. The two most common conditions in which functional intestinal obstruction includes the Hirschsprung disease, which is a disease of the newborn, and in which the Menteric plexus and the Meissner plexus, they do not develop properly, and a portion of the intestine, particularly the sigmoid colon and the rectum, is deprived of the Meissner plexus and Menteric plexus. These are the enteric nervous system, and here the portion here peristalsis are absent, and the food is stuck in the intestine, causing obstruction. The post-operative ileus, which is seen post-operatively after abdominal surgeries, is the most common cause of the intestinal obstruction, and particularly in adults. Small intestine is comparatively narrow. The lumen of the small intestine, duodenum, jejunum, and ileum. It is comparatively narrow than the large intestine, which starts at the ileocecal junction, and its parts are ascending colon, transverse colon, descending colon, sigmoid colon, and the rectum. So the mechanical causes of obstruction present 80% of the cases of intestinal obstruction, and they include hernias, intestinal adhesions, fibrous bends postoperatively that uh, in between the portions of the intestine, and they can cause external compression and intussusception, and the volvulus, which is the twisting of the parts of the intestine against a fixed point. So they form 80% of the mechanical obstructions. The tumors, presence of neoplasms in the intestine, and sometimes conditions leading to ischemia and infarction and intestinal epithelial cell death. They can also cause intestinal obstruction in the tumors, and the ischemic bowel disease or infarction, they account for 20% of the intestinal obstructions. The symptoms that may arise whatsoever the case, but once obstruction occurs, the common symptoms that are observed by the patients are the abdominal pain, distension, particularly of the part of the intestine above the level or above the point of obstruction, and vomiting and constipation. So in this slide we can see different parts of uh, uh, the mechanical obstruction of the intestine. So this is a volvulus, which is twisting of the segment of the intestine against a fixed point, and this type of obstruction is more common in the cecum, sigmoid colon, and small bowel adhesions. The adhesions are the fibrous bands between bowel segments, and they can cause external compression leading to obstruction, and they are most commonly seen postoperatively after abdominal surgeries. The hernia, which is protrusion of uh, abdominal cavity contents through a defect or weakened peritoneal or abdominal wall, and it can become trapped by what we say incarcerated, which may undergo strangulation and vascular compromise of the blood supply, which can lead to ischemia and infarction. The intussusception, what happens then, one segment of the intestine is inverted or invaginated into the another fold or segment. This type of condition is rare in adults and is most commonly seen in children. So what happens in the abdominal hernia? The contents of the hernia in the hernia sac, they may become trapped there. By that what we mean, that the patient normally have hernia, and the patient can, by pushing the hernia sac, the contents of the hernia sac can be reduced. But once they are trapped there, they become fixed here and cannot be reduced. And this is known as the incarcerated hernia. Now, the complication of this incarcerated hernia is that it may become strangulated here. And when it becomes strangulated, the vascular supply to the segment of the intestine in the hernia, it becomes compromised, and it can lead to edema and sometimes to ischemia, infarction, and in more severe cases it can lead to gangrene formation. The common sites for the hernia is the inguinal canal, femoral canal, and sometimes umbilical hernia may occur, and mostly in postoperatively in patients with surgical scars that weaken the abdominal wall and peritoneal wall, may lead to the abdominal hernia. Now coming to the functional type of intestinal obstruction, we will discuss the Hirschsprung disease, and this disease is also known as the congenital Aganglionic Megacolon. So if we think over the name of the disease, congenital means that this disease is present in the birth, and it is commonly seen in the neonates. So Hirschsprung disease is a disease of the neonate. When a baby is born, the baby has missing Menteric and Meissner plexus in her distal colon and rectum, and uh, this absence of the Meissner and Menteric plexus is presented by the name Aganglionic, missing cluster of nerves, missing ganglions. And what happens that the portion of the intestine above the obstruction, for example, if the ganglion are missing in the rectum, so the sigmoid colon may become distended because the obstruction here lies in the rectum. So the distension of the part of the intestine above the point of obstruction, it becomes enlarged, and we say it is the megacolon. So in this picture you can see that there is obstruction in the rectum because of the absence of the Menteric plexus and Meissner plexus. So there are no peristaltic contractions. The food cannot be pushed forward, and as a result, the fecal matter and the food, it will accumulate here and it will distend the colon, sigmoid colon. Now, before we may go further to discuss the Hirschsprung disease, let us have a brief look at the normal intestine and normal peristalsis and normal movement of the food and fecal matter through the intestine. So we know that the cut section of the GI tract anywhere is composed of an internal layer, which is the mucosa. Then outside the mucosa, which itself consists of the epithelial cells and the lamina propria and the muscularis mucosa. So outside the mucosa there is the submucosa, and the submucosa contains the lymph vessels, blood vessels, and particularly the Meissner plexus, which are clusters of nerves arranged in ganglia or neuron bodies, and the function of the Meissner plexus is mainly to control blood flow, absorption, and secretion from the epithelial cells. Now outside the submucosa there is muscularis externa. The muscularis externa is composed of inner circular and outer longitudinal smooth muscle fibers, and in between the circular and longitudinal muscles there is the Menteric plexus or Arbac plexus, also called Arbac plexus. Now this system of the enteric nervous system controls the peristaltic contractions. Normally the longitudinal muscles keep the intestine in a high tone position. By that I mean it is contracted, but when stimulated they relax and allow the food contents or the fecal matter to pass. So the outermost layer is the serosal layer. Now what happens that the circular muscles contract. When stimulated, the circular muscle contract and they prevent the food contents to go back towards the stomach and esophagus. This, at the same time, the stimulation of the longitudinal muscles causes relaxation in front of the food contents, and in this way the food is forwarded or pushed towards the rectum, and this type of coordinated peristaltic contractions, they are essential for moving the food from the mouth towards the anus. As we know, these are the series of coordinated wave-like contractions, and we say that these are peristaltic contractions, and basically the Menteric plexus, it causes contraction of the circular muscle, while it causes relaxation of the longitudinal muscles. So when the longitudinal muscles are relaxed, the circular muscles are in contracted position, it will push the foot forward, and again the same type of peristaltic contractions recur, and repeatedly they push the foot from the mouth towards the rectum. Now, what happens in Hirschsprung disease, that normally in the fetal life during the embryogenesis, there are cells known as the neural crest cells. These neural crest cells differentiate into different types of uh, nerve cells located in the body, and some neural crest cells, they will develop into the differentiated neuroblasts, and the neuroblasts, they start from the mouth and goes on development towards the distal colon and rectum, and the whole gastrointestinal tract is supplied by the nerve ganglions, the Meissner plexus in the submucosal layer, and the Menteric plexus or back plexus in between the circular and longitudinal muscle fibers. This process ends by the 12th week. So the development of the neuroblast, it starts at the mouth and goes on towards the rectum. But if any interruption in this journey of the nerve cells development from the mouth towards the rectum, if it occurs at any part, that part of the intestine will be deprived of the Menteric and Meissner plexus. So in Hirschsprung disease, what happens, that mostly the neuroblasts, they do not develop and descend to the distal colon and rectum. In these area, they are deprived of the Menteric and Meissner nerve plexus, that will lead to the absent peristaltic contractions, and automatically whatsoever is there in the intestine, it will cause obstruction and they will become impacted in this region. So the Hirschsprung disease results from defective migration from the cecum to the rectum, because the most common sites of Hirschsprung disease and the most common sites which are deprived of the nervous enteric nervous plexus are the distal colon and the rectum. Two genes are named, and mutations in two genes, particularly the red gene and EDNRB genes, is responsible for this defective migration of the nerve cells to the distal colon and rectum. And here I want to mention that the same red gene is also involved in Down syndrome, which is trisomy 21 trisomy that occurs in chromosome number 21, and which is associated with mental retardation. And since sometimes the Hirschsprung disease is associated with Down syndrome, and the red gene is said to be responsible for both of these conditions. So what happens, that when the normal migration of the nerve or neuroblast to the distal colon and rectum, which occurs in about round about 8 to 12 weeks. So this is the defective migration of the nerves from the cecum at the ileocecal value to the rectum, and this part of the colon, particularly the distal colon, sigmoid colon and rectum, they are deprived of the Meissner plexus and Menteric plexus, and both these plexes are absent. So what happens, that it will lead to neonatal intestinal obstruction, severe constipation. The newborn baby doesn't pass the meconium, and the part of the colon above the point of obstruction, it will become dilated, leading to the megacolon. So in this picture, we can see that this is a picture in which barium enema, which is a contrast medium, is injected into the through the rectum into the patient, and a picture is taken. So here we can see that this region is obstructed, and this obstruction is because of the missing menteric and medullary plexus. Automatically the food here or the milk meconium, it accumulates here and causes distension of the uh, uh, region that is above the point of obstruction, particularly the sigmoid colon. So this is a preoperative barium enema which show constricted rectum here and dilated sigmoid colon. And this is a picture in which we can see that the colon is dilated, which is known as the megacolon, and the absence of the menteric plexus and medullary plexus lead to absent peristaltic contractions and causes intestinal obstruction here. The complications of this obstructions may be enterocolitis, because we know that a large number of bacteria, they are present and in the colon, and moreover the vascular venous drainage, which is compromised first in the obstructed region, and so there will be secretion of fluids into the obstructed region, and this can cause hypovolemia that we discuss in next slide. And sometimes electrolyte imbalance and fluid imbalance may occur, and this part of the megacolon is prone to perforation, and if it gets perforated, the contents, they will be released into the peritoneum, and it will cause peritonitis and condition of the septic shock. Diagnosis of the Hirschsprung disease is, if suspected barium enema, is given contrast barium. X-rays can tell us about the Hirschsprung disease, but for the confirmation, a suction biopsy is taken, and it is seen that whether the ganglion nerve cells are present or absent. And if they are absent, then it will confirm the diagnosis of the Hirschsprung disease. The only treatment for Hirschsprung disease is surgery, in which the denervated portion of the intestine is resected, and the portion that have the nerve plexus, it is anastomosis is made between the rectum and this portion having the enteric nervous plexus. However, even if surgery is done, it may take a lot of time for the normal peristaltic movements to develop. Now, what happens when there is intestinal obstruction? It may be due to any cause, but once the intestine is obstructed, the part of the intestine above the point of obstruction, it will become distended. When it becomes distended, what will happen? That it will compress the blood vessels in the wall of the intestine, and the venous compression will lead to the secretion of fluid from the blood into the lumen of the intestine, and this will cause a disturbance of the water and electrolyte balance. Now, this water and electrolyte balance will further stimulate the vomiting center in the brain, and there will be further vomiting, and in this way a vicious cycle is made, and the patient is deprived of the water and electrolytes, and in severe cases it will lead to hypovolemia, volume depletion, and this hypovolemia can lead to the hypovolemic shock. On the other hand, the vascular compromise will deprive the intestinal cells of the oxygen, and ischemic changes will occur, and ischemia will lead to death of the epithelial cells, and the anaerobic bacteria which are present, and in the absence of oxygen, because they are anaerobic, they will grow and they will release toxins to the circulation, and this type of infection or sepsis may lead to the septic shock. So in severe and untreated cases, the shock may occur due to hypovolemia and also due to the sepsis. This type of shock is comparatively reversible if fluids are given to the patient to replace the lost fluids. However, this is a serious type of condition in which severe bacteremia occurs, and the sepsis, it spreads throughout the body and can cause disseminated intravascular coagulation and many other complications, and it is presents as a challenge to be treated. So the complications of intestinal obstruction includes the bowel ischemia and death. The distended portion, if pressure inside the lumen of the intestine increases, it can cause perforation, and particularly the anaerobic bacteria that will grow in the absence of oxygen, they will release toxins, and there is bacteremia or septicemia, release of the septic contents into the circulation, which can cause disseminated intravascular coagulation and other complications, and can lead to the septic shock. Thank you very much.